with this procedure. And I put up a couple examples for you. This is a child who's about 4 months out after I did his muscle transposition. And then this child is, I think, about 6 months after surgery. And then it's actually a girl who's 3 or 4 years out. And then this is a boy who's 5 years out. Now, I think in this picture, he may be sucking it in a little bit, but you know, we all do when we take our shirts off at the pool. But I think it's worked pretty well, and all the patients, every family has said there's been an improvement in function, like their cough has gotten better, or they're better at evacuating their bowels, or less urinary problems. I hear a lot of better posture and exercise because, and the series of kids I've done, you can see I've done them all pretty young. I do it about the same time the urologists are working because I figure the kids are already having an operation, so that's a good time to do it, but we'll talk a little bit about that in the future. I want to talk about some of the complications. Well, I've really had only one complication where I've gone back to the operating room. One patient got a seroma, that's a fluid collection, that I took a drain out a little early and I went back and put it in a little bit longer. When I do this operation, in addition to just bringing the muscles up, I also tighten the fascia in the pants over vest style. I do 2 things, so I'm doing both a static and a dynamic operation. And you lift the skin up and then you cut the excess skin off, and because there's too much when you're finished, and you sew it up, and there's a space between those 2 layers, and the body puts fluid in there. And so if the fluid stays in there, it won't stick down, and you can get a fluid collection. And that's happened in one of my early patients. I had to go drain. So now I leave tubes in that go underneath the skin, and I drain them out for about a couple weeks until the drainage really drops down. I know that skin's stuck back together, and then I take the tubes out, and I know that you're not going to get a space for a collection. It's happened to one patient. Prolonged ileus means the intestines aren't working very well. And when I did my general surgery training, we learned that when you operate on the intestines, they stop working for a while. They kind of go into shock. Normally the intestines are a tube, and it'll squeeze in one end, and the next end, and next end. It sort of pushes stuff through. And when you do any operation on the abdomen, that kind of automatic kind of pushing through stops, and it goes on strike for a few days or longer. And so when the urologists are bringing the testicles down, they're just behind the back, the other side of the back. So you have to move all the intestines out of the abdomen to do that operation. It's called a Fowler-Stevens. And I noticed in the schedule I got sent that Dr. Strand's talking tomorrow. I bet he's going to talk about that staged bringing the testicles down. So after they finish, then we put all the intestines back, and they're a little bit swollen, and they don't work as well. And one child went 10 or 11 days, and I couldn't feed him because the intestines just weren't working. So we had to put in an IV where you could feed, you know, it's not exactly, you know, we joke it's steak and potatoes by vein, but it's really not as much calories as it would be if your gut is open. And I can imagine I'd feel pretty miserable if I wasn't getting any food for 10 days. So that's happened to one of my patients, and another one went about 8 days, I think, and then the rest a bit sooner. I've had one or two patients where I wasn't combined with the urology procedure, and it was pretty quick, like a couple of days, a day or two. The kids were doing pretty quick. And the last thing are scars. I wanted to mention, you know, you do get scars on the legs, and this is the most prominent scarring I've had on this boy, but I thought, I don't know, I hope you can see it. Sometimes the best treatment for a scar is to take a picture of it, because it looks worse in person than when you see it. But you do get scars on your legs, and so I'd say that as a negative of it. But the positives are, I've had patients that have better coughs and you know, one patient got off a vent immediately afterwards, and less constipation and better posture. And all the parents say if the kids weren't walking yet, right after surgery they got up and started walking. So I've been very, all the observations I've had are very favorable. But here are the problems with observations. They're not really scientific. One is the patients I operate, because they're young, they're getting older at the same time. So if I see them a year after surgery and the parents say, oh, they're doing all these things they weren't doing before surgery, but yeah, they were also getting older. And so if I was operating on patients that were fully grown and had stopped that, you know, development part of their lives, it'd be easier to see a before and after difference and attribute it exactly to the operation. But because I'm operating on kids on average who are 18 months to 2.5 years, that's always been a question in my mind. How much is it that they're just getting stronger, or whatever muscles they had are improving? Although I can tell you, all the patients I operate on, I have them lie down and try and sit up afterwards and put my hand on their stomach, and I can feel those muscles just tensing right up. So, so I believe it's working, but it's an observation. It's not an actual scientific measurement. And the other thing is that surgeon parents want to see an improvement if, you know, you go through an operation, especially if your child is in there for 10 days and can't be fed for 10 days and before you get out of the hospital, you want to see any improvement you can in your own mind to make it worth it. And so, so that's another problem with observations. I know the muscles work because I can feel them flex. And the other thing that got me interested in doing this operation is I used to do a fair amount of congenital hand surgery, and one of the problems kids can be born with is absent thumb. And most of the function of the hand comes from the thumb. So if you have no thumb, your hand's like kind of like those highlight scoops. You can't really do much with it, but you can do lobster pinch. But if you have a thumb, then you can oppose it, and you know, that's what sets it apart from so many animals, just increase in function. And there's an operation you can do where you take the index finger and you swirl it around to the position of the thumb and you shorten it. And you reattach muscles like the same direction as the muscles of the thumb. And when you take the bandages off kids the first time, and they look at their thumb and move it just a couple times, in a minute or two, their brain just treats it like they've always had a thumb. I mean, these are kids that are born without thumbs that you'd operate on at age 5 or 6. In just 1 minute they learn and it gets that function. So it makes sense to me that when, you know, you move muscles up here, the brain will very quickly treat it like it was supposed to be your stomach muscles. So at least I believe that that's possible. But these are observations and they're not scientific measurements. And a lot of questions remain. Now, it's true that, I mean, I know of one other doctor, Dr. Gurr, that's done this operation, and I've heard there's a doctor in Canada. Maybe you guys know of any doctors that else have done this.
We just had a little guy about 2 weeks ago, upstate New York, had this done. Yeah. I don't know who the doctor was, though.
He called me and asked me about how to do it.
He did. Yeah.
Yeah.
Wow.
And so, so you know, with 6, I may have more experience than a lot of people, but that's not a whole lot of experience. It's a pretty straightforward operation. It's not technically very difficult. And plastic surgeons, our basic training is learning how to move muscles around and things like that. So I don't think it's a completely challenging thing. I think, though, after 6, I sort of feel pretty comfortable with the operation. If I've done 60, I bet there are things that I would learn that I could do just a little bit better. So I don't know what the indications are for surgery. Like, I don't know how much loss of muscle do you need to have before it's a really good idea to do it. I've told you that 2 patients so far have had a little bit of muscle that I saw that I didn't expect to see. I couldn't feel it on exam, but I decided not to move those muscles. And I'm not sure in retrospect that was a good idea, but I just don't know because I don't have that much of experience. So I'm not sure what the indications for surgery are, but I suspect it probably help. It's really likely to help the majority of people, but I don't know for sure. And I also don't know what the ideal age is for surgery. I've been doing it at the same, I try to make the urologists wait as long as possible to bring the testicles down. And I just don't know what the best timing is for that and the pros and cons of that. But I do know that when you're a baby, your heads are disproportionately large and the rest of your body is disproportionately small. You know, if you look at a baby, about 1/3 of their length is skull almost. But then if you look at someone like me that's fully grown, a very small proportion of my head is in relation to the length of my body. So if you look at the length of the muscles in the thigh when you're young, it's not as long relative to someone that's hits kind of skeletal maturity. And so in the younger kids, when I'm bringing the muscle up, I can't get it all the way up to the rib cage, like the line drawing in Dr. Gurr's paper. And I'm not sure he got all the way up there too. I was very interested to see in that publication in 2000 that he had scored the fascia, because I had learned just the first one I did, there's a fascia layer on top of the muscle, and I found I could get a lot more length if I scored that and made those little kind of cut marks in it. It allowed it to stretch more. So in some young kids,